The objectives for the lecture will be to distinguish between normal and abnormal anatomical and biomechanical considerations for patellofemoral pain, identify risk factors associated with patellofemoral pain, determine signs and symptoms associated with patellofemoral pain, and understand an evidence-based approach for the management of patellofemoral pain. There's been two primary research agendas for the management of PFP and physical therapy: the treatment for patellofemoral pain and the treatment for patellar tendinopathy. Oftentimes these overlap a lot. However, there are some specifics with patellar tendinopathy that may not apply to somebody who does not have that tendinopathy presentation. Interventions are guided by impairments and comparable signs, and we should always be trying to focus on a multimodal approach, as exercise therapy is critical. However, there are some other factors that we may need to address throughout the plan of care. Remember as well, the clinical practice guideline brought in those classifications, and they recommended some specific treatment interventions depending on the classification. Like I said before, hasn't been studied yet, but it would make sense if you see some specific impairments that you would address those impairments. It's a good approach that we should be utilizing in our plan of care. I think it begins by understanding what patients want from our education and management for patellofemoral pain. And I want to talk a little bit about the effectiveness on pain education for patellofemoral pain. In addition to looking at exercises that are most effective for PFP, we're going to investigate why these exercises are effective as well. Before we get into specific interventions, I think it's important that we understand what patients' expectations are when they come in with patellofemoral pain. This study looked at the patient experience of the diagnosis and management of patellofemoral pain. They wanted to understand what patients wanted to know. Okay, so this study was conducted by Barber and Brad Neal. You've seen his name before in some of the articles I've referenced in this patellofemoral pain category, and we're going to continue to reference. He's done a lot of work in this area, and he's put out some really good stuff recently. So this study was a qualitative exploration of 12 patients, and they identified 3 common themes from these patients. The patients wanted to know a diagnosis that explains their pain. A common quote was, "It's nice to be told what it is that's wrong." They also wanted to receive tailored interventions. They mentioned everyone copes and reacts differently. And they also said that appropriate education to optimize their experience and outcomes. So they wanted more information. If I'd been given more information, I think I'd know how to deal with it more. 3 common themes that we need to be addressing with our patients who are presenting with PFP: diagnosis, tailored interventions, and information for them to have. I think that's pretty consistent with everything we've been teaching over the last year. Is we need to provide quality education, quality tailored interventions, and quality information for our patients. We know that education is a vital part of what we do for our patients, but what about pain education versus exercise as a management strategy for patients dealing with patellofemoral pain? Well, this study was conducted in 2020, and it looked at different articles that focused on an exercise group and an education group. And what they found was that both for short-term and medium-term, there was no difference in the groups. So it didn't matter whether they only received education or exercise. There was no statistical significance in the findings. It makes sense to me that high quality education versus exercise may not have a ton of difference in relationship to their pain levels, but what about their function? Well, the study also looked at function, and they found in the short term, less than 12 weeks or up to 12 weeks, there was no difference in education versus exercise in knee function. You can see how it's starting to shade over towards exercise, but it wasn't significant enough to say that there's a difference between the 2 groups. So to summarize that, high quality patient education produces similar outcomes and improvements in pain at the short term and long term, in addition to providing similar outcomes in knee function in the short term. Now, I don't think this means that we're just going to go and educate our patients and only educate our patients. I think most of our patients still benefit from some level of other interventions. However, I think This also shows how important pain education is for our patients who are going through patellofemoral pain. And if we can focus on that as part of our management strategy, hopefully we start to see a reduction in the persistent pain in patellofemoral pain. Best evidence is telling us that we need to be focusing on assessing and addressing the yellow flags, and psychologically informed physical therapy is a main contributor to that. This study done by Mitchell Selhorst and his group in 2021 was a randomized control trial where they took 66 adolescent athletes and they were divided into two different groups. The first group was the intervention group, where they watched a brief psychologically informed video discussing pain-related fear avoidance and pain catastrophizing behaviors. And the other group was a control group, where they were assigned to watch a video that discussed basic anatomy and factors contributing to PFP. The results showed that the intervention group had significantly reduced pain-related fear, pain catastrophizing, and improved function up to 2 weeks. But beyond 2 weeks, there was no difference. Part of me wonders if the reason for the no difference beyond 2 weeks is because they only watched the video once. It was a brief video at the initial session, and after that, psychologically informed physical therapy didn't have anything to do with their plan of care. So it's impressive to me that that short video at the initial session resulted in 2 weeks of decreased fear, catastrophizing, and improved function. But it also should emphasize the fact that we need to have this ongoing conversation and continually address some of these pain-related fear behaviors and pain catastrophizing behaviors throughout our plan of care. This is another article published by Brad Neal in 2022. It's a really large systematic review with meta-analysis looking at treatment for patellofemoral pain. They included 65 randomized control trials, and their goal here was to determine which interventions had primary and secondary efficacy. They define primary efficacy as outcomes were superior to sham, placebo, or wait-and-see approach. So, for example, let's say knee extension exercises were superior to placebo. That would be primary efficacy. Secondary efficacy showed that outcomes were superior to an intervention with primary efficacy. So the thing that we're really looking for here is to see which ones had secondary efficacy, because they're superior to ones that outperform sham, placebo, or wait and see. Here's a list showing the interventions that had primary efficacy. So they're superior to sham, placebo, or wait and see. Knee-targeted exercise therapy had the highest certainty. Combined intervention compared to wait and see had superior outcomes. Foot orthoses compared to sham foot orthoses had superior outcomes. And then lower quadrant manual therapy compared to wait and see had superior short-term outcomes. You can see here there's only one study that looked at medium-term and long-term outcomes. That was the foot orthoses, and there wasn't any certainty that it led to superior outcomes. So it would be interesting to see these other categories, whether they had medium and long-term outcomes. But as of right now, based on the information we have, for short-term outcomes, these interventions outperform placebo, sham, or wait and see. I also do think that it's interesting that the foot orthoses did not lead to medium and long-term differences, and I wonder what the reasoning behind that would be. It doesn't necessarily surprise me. I think oftentimes patients who go in and get their foot orthoses, they are really excited about them initially and don't have that long-lasting relief, and they look for the next thing to help fix their pain, and the next thing, and the next thing, and they keep looking for a fix. But anyways, I thought that was an interesting finding. Found 2 interventions that had secondary efficacy. Remember, secondary efficacy is superior to interventions to primary efficacy. And they found that hip and knee targeted exercise therapy was superior to knee targeted exercise therapy. They also found that knee targeted exercise therapy and perineural dextrose injection was superior to knee targeted exercise therapy. So for us in the clinic, we should probably be prioritizing hip and knee targeted exercise therapy to help reduce patient symptoms with PFP. Obviously, we're not going to be giving them any injections, but if we're not seeing the progress that we're hoping for, we may consider referring the patient for an injection in addition to continuing with the exercise. So we know that hip exercises can be helpful for patellofemoral pain. We just saw that its secondary efficacy combined hip and knee interventions is superior to knee interventions alone. But we also know that weak hips do not lead to patellofemoral pain. So why do we think that hip strengthening can help with PFP? Well, the answer is it's still unknown. One study has specifically looked at the mechanisms behind why hip-targeted exercises improves pain in people with PFP. They had a hip-targeted exercise group and a control group who were provided with foot orthoses. The hip-targeted exercise group went to PT 3 times a week for 4 weeks, and the orthosis group went to PT 1 time a week for 6 weeks. The results showed that hip exercises resulted in patients being able to do more pain-free squats and also reduce their general pain levels, but they didn't improve hip strength in any motion other than external rotation. And they also found that there was no association with any of the psychological factors. So this study shows that we are still unsure of why hip exercises with PFP, we're unsure why they still help with PFP. It's not because of improved strength, and it's not because of improvements in psychological processes. They recommended further research to get a better idea of why. I'd also be interested to see what the results would have been if they included psychologically informed PT along with the hip exercises, see if that changed anything, because they didn't address the psychological aspect of it throughout physical therapy in general, whether they got foot orthoses or if they got exercise. They didn't take a psychologically informed approach. So I'm curious if they did, if they would have seen those psychological markers improve at all. To just add a little bit of information about patellar tendinopathy before we look specifically at interventions. It's a very common chronic tendon injury. It occurs in active individuals mostly. In fact, 45% of elite athletes in jumping sports have had patellar tendinopathy. It's typically a load-related issue, and it's been shown to limit sports participation and limit participation in physically demanding work, which can result in significant costs to our healthcare system. You've seen this slide many times before, so just to reiterate, 3 stages of tendinopathy that falls on a continuum: reactive tendon disrepair and degenerative tendinopathy. The main findings that are consistent across the literature for the treatment of patellar tendinopathy is we need to load the tendon. Most research has been focused on eccentric exercises. However, there's a lot of emerging data looking at progressive tendon loading exercises, and it seems like that's a really promising strategy that we should be implementing into our patient care. In this randomized clinical trial, they had 76 patients with clinically diagnosed and ultrasound confirmed patellar tendinopathy, and they were randomly assigned to a 1-to-1 ratio to receive progressive loading or eccentric loading. The primary endpoint was the clinical outcome after 24 weeks. They tried to isolate only patellar tendinopathy patients, so in order to be a part of the study, they had to label their symptom location as the picture E here, so along the patellar tendon. If they didn't have symptoms there, then they were not a part of this study. The eccentric exercise group had 2 stages. It began with the single leg decline squat, followed by sport-specific exercise. You can see the pictures on the right and how they would progress from no weight to resistance and then eventually return to sport. The progressive tendon loading exercise group went through 4 stages. For the isometrics, they either did a leg press or a leg extension, and they did 5 reps at 45 seconds. They focused on mid-range knee flexion here, so they tried to be around 60 degrees. And it was a quadriceps-based isometric, and they required the patient to achieve at least a 70% maximum voluntary contraction. Stage 2 consisted of the isometric exercises of stage 1 performed on every first day, and then the isotonic exercises performed on every second day. The isotonic exercises were also performed as a single leg press or a leg extension. Started out with 4 sets of 15 reps between 10 to 60 degrees of knee flexion and progressed to 4 sets of 6 reps, allowing for increased range of motion. After the isotonic exercises, you move on to stage 3, and that consisted of plyometric loading and running exercises on every third day, starting with 3 sets of 10 repetitions using both legs and slowly progressing to 6 sets of 10 reps using one leg. Isometric and isotonic exercises were continued on every first and every second day, respectively. Stage 4 consisted of sport-specific exercise, which were characteristic of the type of the sport. Whether you were a basketball athlete, it might be more basketball-centric exercises. If you were a volleyball athlete, more volleyball exercises. And patients were instructed to gradually return to sport-specific training, performing every 2 to 3 days to allow for recovery after each session. The results showed that both groups improved significantly both at 12 weeks and 24 weeks for pain and function assessed by the VISA-P. However, the authors concluded that the progressive tendon loading exercise group was significantly better than the eccentric exercise group. They also noticed that there was a higher return to sports rate in the progressive tendon loading exercise group. So according to this study, progressive tendon loading exercises are more valuable than eccentric focus exercises for patients going through patellar tendinopathy and goals of returning to sport. To summarize interventions for patellar tendinopathy, I want to pull forward this narrative review that was published in 2022. It looked at a lot of different interventions for patellar tendinopathy, and what they found was that exercise therapy is most effective. Eccentric exercises and progressive loading exercises, and we just discussed how progressive loading exercises seem to show promise in being superior to eccentric exercises. They also found that extracorporeal shockwave therapy, dry needling, and orthoses are no more effective than eccentric exercises or placebo. They also found for short-term effects, isometric, isotonic exercises, patellar strap, sports tape, and kinesiotaping did improve outcomes. And then for long-term effects, they found that progressive tendon loading, dry needling, PRP injections, and extracorporeal shockwave therapy had positive long-term effects. You'll notice that there are what seems to be conflicting statements within this article, and that's because it's a narrative review looking at 22 randomized control trials. Some of the randomized control trials showed that dry needling and shockwave therapy were not effective compared to placebo, while others showed that they had long-term improvements. What that should tell us is that these do not have enough definitive evidence to show whether or not they are evidence-based interventions. We should proceed with caution when considering these interventions and should fix our attention to progressive loading exercises, as that's what's being shown to be most effective currently in the literature. Here's a chart describing some management strategies that you may consider implementing into your clinical practice. If you're a visual learner and you like to print out charts and have them in front of you just to give you ideas, this may be a valuable resource for you. Here's just a couple other pictures of potential interventions you may consider using for patients with patellar tendinopathy or patellofemoral pain.
Please let me know if you have any questions and feel free to contact me directly.